Hello and welcome to another intensivecarehotline.com live stream. I'm your host, Patrick Hutzel from intensivecarehotline.com. I'm the founder and editor of intensivecarehotline.com. In today's YouTube live stream, I want to talk about 10 alternative treatment options the ICU team hasn't told you about. And before we go into today's topic, just you might wonder what makes me qualified to talk about today's topic. So I am a critical care nurse by background. I have been working in critical care for over 20 years in 3 different countries. I have also been working as a nurse unit manager for over 5 years in intensive care. And I have been consulting and advocating for families all around the world in intensive care since 2013, for over 10 years now. I am also the founder and managing director of Intensive Care at Home, where we provide intensive care at home nursing services for predominantly long-term ventilated adults and children with tracheostomy at home, but also for patients with BiPAP, CPAP, home TPN, anyone that needs a critical care nurse in the home is pretty much what we are providing with intensive care at home. So today's video was, as a result of, me talking to intensive care units directly, me talking to families in intensive care directly, understanding their frustrations, understanding their pain points. And, I always come back to my own conclusions, which is, that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And clearly, this video today and those alternative treatment options are a result of, when I consult and advocate for families in intensive care and talk to intensive care units directly, they're not even telling families half of what's going on. And they're not even telling families about treatment options. They're trying to eliminate second opinions for families in intensive care. They're trying to eliminate hospital transfers, because other hospitals may have other treatment options for them, And by the same token, with our consulting advocacy, we get better outcomes, and we have saved lives simply just by, advocating for our families and making sure intensive care teams know our families have someone on their team that understands intensive care just as well as the intensive care team does. And it makes all the difference, right? For example, we have many families reaching out to us and saying, my loved one was in intensive care last week or last year or whatever, and they passed away. And because we agreed to a withdrawal of treatment, and then my loved one passed away, and now we're having second thoughts. You do not want to be in a position like that. You do not want to be in a situation where you have regrets. When you have a loved one in intensive care, you need to be proactive. When you have a loved one in intensive care, you need to make sure that no stone remains unturned, because if your loved one is critical, it means they're probably as close to death as they've ever been before. And if you are not asking the right questions, right, if you are not arming yourself with critical and potentially life-saving knowledge, your loved one could be doomed. If you're not arming yourself with a team around you that can help you navigating this complex territory that is intensive care step by step, you're probably fighting an uphill battle. And then you'll probably be reaching out to us a year later after your loved one has passed away, and you're wondering, well, why did I not take action? Why did I not find someone who can help me dealing with this critical situation and get results that actually benefit me and my family? So that's really what we do with intensivecarehotline.com. We're walking people through the experience, but we also get real outcomes. Case in point, have a look at a a video blog that I did a couple of months ago with a client, with one of our previous clients, where we clearly saved a life by advocating for our client, because the ICU basically said, well, that's it, we're going to withdraw treatment, this patient won't survive. And as soon as we got involved and looked at the client's case, clearly there were other treatment options that the intensive care team hasn't even educated the family on, which then leads me to my first alternative treatment option the ICU hasn't told you about in this situation. The client, 59-year-old client, was in ICU after falling off a scaffolding headfirst, had a cardiac arrest, massive traumatic brain injury, and he had high intracranial pressures. He had sepsis. He was very critical, no question about that. And the ICU team told the family that he won't survive, and with a small chance that he will survive, he won't have any quality of life if he ever gets out of ICU. Anyway, what we learned pretty quickly when we talked to the ICU and when we looked at the medical records, it became evident very quickly that the ICU team did not tell the family about the option of a tracheostomy, right? So that's the first alternative treatment option, that ICU teams don't even tell families in intensive care that it's an option. Anyway, by advocating and then also, of course, getting a tracheostomy for this particular client, he survived. He survived his intensive care stay, and you can actually see that he's in person on a call with me and his family, where him and his family share his journey and how grateful they are that they found intensivecarehotline.com. They found that I could advocate for them, because he's very grateful to be alive. His family is very grateful to have him around, and it made all the difference. So that's one treatment option that the ICU team in many cases is not telling families about. And once again, you don't know what you don't know. You don't know what to look for. You don't know what question to ask. You don't know your rights, and you don't know how to manage doctors and nurses in intensive care. And that's where we can help you very, very fast. Also, with tracheostomies, I also want to mention on that point, which goes hand in hand with what they often don't tell you, is when someone has a tracheostomy in intensive care, the goal is always to get a patient off the ventilator as quickly as possible. But if for whatever reason that can't be achieved, if the ventilator can't be removed in spite of a tracheostomy, or if the ventilator can be removed, but patient is still stuck with a tracheostomy, then another treatment option that intensive care teams often don't tell you about is intensive care at home. With intensive care at home, we are providing a genuine alternative to a long-term stay in intensive care, predominantly for long-term ventilated adults and children with tracheostomy, but also for patients that are BiPAP, CPAP ventilated. And as I said, if they don't have a ventilator but have a tracheostomy, they still need an intensive care nurse 24 hours a day. And we offer that genuine alternative for a long-term intensive care stay at home, right? So it's often something not all ICUs know about either. So they're not telling you about that. If they do tell you about it, that's fantastic, and you should look into it. Go to intensivecareathome.com so that you can actually have a look there what's available for you. Also for patients with home TPN, but I'll talk about TPN separately. Okay, let's slightly shift our focus here and focus now on respiratory issues as well as cardiac issues, because that's where I found that families have the biggest deficit about knowing what treatment options are available for their loved one in intensive care. So over the years, I've looked after dozens, potentially hundreds of patients in intensive care with heart failure, lung failure. And, I do believe I had a really good understanding of what treatment options are available, even for the most severe critical illnesses in intensive care. So let's start with heart failure, right? So One thing that I found is, the standard treatment in intensive care for heart failure, in intensive care specifically, is often medications such as milrinone, dobutamine, especially if ejection fraction is low. And there's often Lasix in the mix, furosemide to keep a patient quote unquote dry and making sure they're not fluid overloaded so that the heart can actually is not decompensating and can actually maintain its pump function, and its contractility. If that's all not working, then as I said, milrinone, dopamine sometimes are standard drugs in intensive care, and they can only be given in intensive care, generally speaking. But then other medications that I've seen given and that families don't know about is, for example, levosimendan, also known as Simdax, which is a short-term inotrope or vasopressor that increases contractility for the heart, in the short term, right? And it can be very effective. I've seen it very effective, especially when contractility is low, especially when ejection fraction is low. So I've seen levosimendan / Simdax being given with much benefit for a patient. Now, other things that I've seen, especially when it comes to heart failure, is ECMO, for example, right? So a lot of patients with heart failure can go on ECMO. ECMO is like a bypass machine. It'll take over the function of the heart, in some instances of the lung, but I will talk about that separately. And then, that can buy the patient time. The heart can recover. If, God forbid, the heart can't recover, maybe after cardiac arrest, after a massive heart attack, whatever the case may be, then the option of a heart transplant might need to be given, or the option of an LVAD or an RVAD needs to be given. LVAD stands for left ventricular assist device. It's basically taking over the function of the left side of the heart. If it's an RVAD, it's a right ventricular assist device. It's taking over the heart function of the right side of the heart. So that can also be used as a bridging to a heart transplant. Okay, so don't get me wrong, those are not easy processes, but what I have found after having consulted hundreds, potentially thousands of families in intensive care over the years, and also after having looked after thousands of critically ill patients in intensive care in ICU, those treatment options are not even mentioned as an option. And there are plenty of hospitals all around the world, plenty of ICUs, that do not know or don't have those resources available. And what they often do then is they tell families, well, you got to, the only option for us here is to withdraw treatment. Whereas when I hear about these situations, when we work with clients one-on-one, my approach to that is, well, but they offer that in other hospitals. Have they offered you a transfer to another hospital? And the answer is no, right? And then, depending on how long a patient has been in ICU for with, let's just say with heart failure, it might be too late to make that transfer because the patient by now is too debilitated, has deteriorated too much, right? So it's really important that you from day one get a grasp on things, that you do your research, that you can maximize beneficial treatment and beneficial options for your critically ill loved one. If you're not doing that, there have been so many families over the years that come to us when it's too late, right? You can't wait in situations like that. You have to do your own research. It is a deadly mistake, quite literally, if you're not doing your own research. You don't want to be, having a loved one in intensive care is a once in a lifetime situation. You cannot afford to get it wrong. For us, reviewing medical records to see whether there's been medical negligence after your loved one has passed away, we can do all of that, but it's much better if you use your time and your resources to work with us one-on-one while you have a loved one in intensive care, so we can actually get real beneficial outcomes for you and your family. So, while we were on the topic of ECMO for heart failure, let's talk about lung failure here. Let's talk about ARDS, and let's talk about, you know, the COVID pneumonia and the COVID ARDS, but even ARDS before COVID even existed, was a big issue in intensive care for our clients, in terms of that families were not told all treatment options. You know, the mortality in intensive care for patients with severe heart failure, severe ARDS, and lung failure is higher in comparison to other conditions. And if you don't know that there are treatment options out there, that the ICU team is not telling you about it, again, your loved one's life might slip through your very fingers, and you will not even know what's happening in this moment if you're not doing your own research. So let's quickly talk about ARDS, pneumonia in ICU. What treatment options are available beyond the standard treatment, which is antibiotics for bacterial pneumonia, you know, antibiotics for bacterial ARDS. During COVID, it was the remdesivir for COVID ARDS in particular. But once those treatment options were exhausted, again, we have also found ICUs were not offering other treatments, because probably the pressure on beds was so high during COVID that they felt like, well, the easiest way to deal with this is by withdrawing treatment, by withholding information from patients and families, and by saying, well, you know, the best option here is to withdraw treatment and you know, stop life support and let patients die, because they needed the beds. And you know, and they still need the beds even to this day, because now all the staff have left, and you know, now they might have beds but they might have no staff, so the pressure on beds is just as high as it was before COVID or during COVID. Okay, so again, what are treatment options in those situations when standard approaches such as IV antibiotics, antivirals fail? So the first approach, especially when someone is on a ventilator, again with ARDS pneumonia, and they're on 100% FiO2 ventilation, therapy is maxed out, you know, there's not much more support they can give. One option could be prone position, right? Basically what that means is you're putting a patient upside down, tummy down, head down, and that can be very effective, but it can also be very taxing for the patient. And you know, they need to be induced into a coma, they need to be heavily sedated, they often need to be paralyzed. When I say paralyzed, mechanically restrained, mechanically paralyzed with paralyzing agents, you know. And then once you wake them up, you can get rid of the paralyzing agents, but again, that comes with many side effects. And you don't want to wait for prone position to kick in when your loved one is on 100% of oxygen on the ventilator, on 100% of FiO2, because by then it might be too risky to do the turn. This is why it's so important that you are informed from day one what options are out there, so you're not going in a situation like that where the options are limited. So then, if prone position is failing with lung failure or pneumonia, the next step is once again ECMO. Just as I said, ECMO for heart failure, ECMO is also an option for lung failure. So ECMO is a bypass machine, can take over function of the heart or a lung for a period of time. Once again, giving the lungs time to heal, right? And again, so many times I've seen when talking to ICUs all over the world that ICUs are not being transparent about ECMO being a treatment option for lung failure, right? During COVID in particular, you know, where we worked with families one-to-one and we said, well, have they told you about ECMO? And they said, well, what's ECMO? And the ICU did not offer it to them, often because they didn't have ECMO available in any specific ICU. But then what should have happened is they should have transferred this patient to another ICU, right, where ECMO was available. Okay, so really important that you know and understand, just because the treatment option might not be available in your current ICU, that other ICUs probably have that treatment option available. So it's critical, once again, that you familiarize yourself with the lingo, that you have someone on your team, like myself from intensivecarehotline.com, who understands intensive care inside out, who can walk you through the process step by step. Okay. Other treatment options that I found in intensive care units are not telling families about is ibuprostanol, again for lung failure. ARDS in particular. It's a nebulizer. It can be very effective for ARDS. Nitric oxide, another treatment option that is available for lung failure, ARDS in particular. And again, sometimes we hear, when we suggest that to ICUs and we hear the response, oh yeah, that's old fashioned and we don't do it here. Okay, well, you don't do it here, whatever your excuse is, but if you can't save a life, why not try? If you're telling the family, well, your loved one is going to die, and then we come in and say, well, but have you tried this and have you tried that? Have you tried ibuprofen? Have you tried nitric oxide? Is ibuprofen available? Is nitric oxide available? And then they say, with nitric oxide in particular, it's not always available, but similar to ECMO, then a patient needs to be discharged to another hospital, right? Another treatment option when it comes to lung failure, especially ARDS, which often goes hand in hand with pulmonary hypertension, is Viagra or sildenafil, right? Again, we are finding ICUs don't talk about it, right? They are not transparent with families in intensive care. Now, one more treatment option for heart failure, which I forgot to mention earlier, again, that families in intensive care are not being made aware of, is an intra-aortic balloon pump, right? Seen it many times, looked after many patients with an intra-aortic balloon pump in intensive care. It can be the intermediate step between, inotropes, vasopressors, and ECMO, right? Sometimes when an intra-aortic balloon pump doesn't work, then the next step might be ECMO, right? So it's gone a little bit out of fashion at the intra-aortic balloon pump, but it's definitely still there. And, it can be a bridge to ECMO if the heart doesn't work, okay? So then let's move away from cardiac and respiratory conditions for now. Let's move towards ICP management or traumatic brain injuries. What are treatment options there that intensive care teams often don't tell families in intensive care? So when someone has a traumatic brain injury, God forbid, and they have high intracranial pressures and they need ICP management, first line treatment is always dark room, induce coma, minimizing noise, keep everything calm so that the brain isn't getting stimulated and that ICPs stay within a normal range. Often what happens after traumatic brain injury, there can be bleeding, swelling in the brain, and ICPs, intracranial pressures, also known as brain pressures, go up and they go high, and then there could be irreversible and permanent brain damage if ICPs aren't kept below 20 centimeters of water, and CPPs, cranial perfusion pressures, can't be maintained above 60 centimeters of water, right? So really important, those numbers, to manage those numbers very tightly when someone comes into ICU with a traumatic brain injury. Other treatment options there are, for example, not only the sedation, also paralyzing agents, right? So if you paralyze someone with a traumatic brain injury, chances that ICPs stay lower are there. So that could be a treatment option. Another treatment option could be mannitol. It's a diuretic and it flushes excess water. Again, that keeps the brain pressure low. Same with hypertonic saline. It's often 3% or 6% saline. If you give that, once again, water is being drained from the brain to keep intracranial pressures low. And once again, we've seen over and over again that those treatment options are not mentioned. Families are completely unaware that these treatment options are even a thing, right? So again, you as a family in intensive care, you need to inform yourself from day one what's really happening, what is available for you, and also, are you in the right ICU? Do they know about alternative treatment? If they don't, do they know other hospitals that have that available, and are they helping you to get your loved one to another hospital, to another ICU? It's okay that some ICUs are not as well resourced as others. That can happen, of course, especially if you are somewhere rural or regional. But then what needs to happen next is they need to give you access to those other hospitals where your loved one can get best care and treatment. So we talked about that. And lastly, another treatment option that we're finding is often not being shared with intensive care, with families in intensive care, is TPN. So countless families over the years that we worked with that have a loved one in intensive care, for whatever reason, they can't be fed with a nasogastric tube or with an orogastric tube, and then they're starving, right? And it's clear in intensive care that with the research being out there, the earlier you can start feeding a patient, the less likely there are complications, the less likely these patients are dying, and then we've worked with someone not too long ago who was basically not having any nutrition for about 10 days. What a disgrace. And the intensive care team had not educated the family about the option of TPN. TPN stands for total parenteral nutrition. It's also known as intravenous nutrition. It's a very good alternative as opposed to the nasogastric tube feeding, if that can't be maintained for whatever reason. Now ICUs often have the comeback of, well, TPN, it's too much of an infection risk. Yeah, it is an infection risk, and I'll come to that in a minute, how to manage it. By the same token, the patient is getting nutrition, which is critical, that the patient is getting nutrition. You cannot starve a patient. So patient then needs a central line or a PICC line to have the TPN, right? And again, patient can safely have TPN in intensive care. It might be a little bit more complex when the patient is going to a hospital ward, because staff need to be competent with a central line or a PICC line, which is often an intensive care nursing skill. So, but it is a treatment options that is often being withheld from families in intensive care unless you know what you're talking about, unless you're asking all the right questions. The number of times we have had clients in intensive care where they were literally starved to death. They were literally starved to death, and no one, came to their rescue until we got involved and saying, well, if you can't feed a patient, we got to give them TPN, right? And every single time patients then had TPN instead. Because again, we are professional advocates and we get outcomes for patients and families. We get results because we do know what we talk about, and families in intensive care don't know what they don't know. Okay, so next. Another treatment option, lastly, that families are often unaware of is cooling therapy for cardiac arrest, right? Most patients in intensive care that have a cardiac arrest or go into intensive care with a cardiac arrest, they should have cooling therapy. And again, families can't talk. Families don't know about it. I'm sorry, I was just carried away with my thoughts for one moment. They should know that cooling therapy is protecting the body when it comes to cardiac arrest. It's protecting other organs so that a recovery can take place down the line. Okay. Then let's so those were the treatment options, the more than 10 treatment options, alternative treatment options that the intensive care team hasn't told you about. Okay, you just got to give me 1 second. I just got to respond. just got to respond to a text. I do apologize. And then I'll answer other questions that came in during the week. Okay, now let's look at questions that came in during the week. And if there are any other questions, please type them into the chat pad, of course. If you have any burning questions now, please type them into the chat pad and I will get to them. Now, and if you want to dial in live on the show, you can do that as well. Just go to intensivecarehotline.com and call any of the numbers on the top of our website. If you want to dial in live on the show, you can do that as well. So let's get to questions that came in during the week. This one is from Thomas. Thomas says, my father is on the ventilator and immobile. He has Guillain-Barré syndrome in intensive care. We need help. That is very sad to hear, Thomas, about your dad. If he's on a ventilator and he's immobile and he's got Guillain-Barré syndrome, from my experience, you could brace yourself for a long-term stay in intensive care. I mean, Guillain-Barré syndrome often leaves patients paralyzed, at least temporarily, leaves them completely paralyzed. And that is a big challenge. So often patients in intensive care end up with a tracheostomy after Guillain-Barré syndrome. They often need immunoglobulins because to get the immune system going again. And then patients, because they are immobile, they can stay in intensive care for months on end. I've seen it many times, and there's no need for that. They could go home with intensive care at home. So again, if your dad will be stuck in ICU for months on end, which is often the case with Guillain-Barré, I strongly recommend that you go to intensivecareathome.com and check out the options here with intensive care at home. We are currently operating all around Australia in all major capital cities, including rural and regional areas. We are an NDIS funded service provider, TAC, DVA, and IISQ in Queensland, as well as iCare in New South Wales. So, you should definitely check out what the options are with intensive care at home, rather than worrying too much about what's happening in ICU. Go and look at options outside of ICU. Right, so then there is a lady or a gentleman, Hope, who asks, do you have recommendations to avoid dialysis for patients with stage 4 kidney disease? Any help is appreciated. Thank you. Now, I don't, Hope. I really don't. I do believe for stage 4 kidney disease, the challenge is that for stage 4 kidney disease, I do believe the option is potentially a kidney transplant, right? I do believe that might be the option forward here, Hope. My recommendation here is talk to a nephrologist and find out what the options are. But I would imagine it also depends on how long has your family member had the stage 4 kidney disease. This is a recent thing. Is it an ongoing thing? Is it a chronic thing? Do you know? If you could share that with me here, that would be great. Hope the more information, the better. While I'm waiting for your response, I'll carry on with the next question that came in this week. This question is from Terry, who says, my sister is in ICU. She has CML lots of fluids on one lung has collapsed. She also has a pneumonia. Now, with CML, that's basically a form of leukemia. I'm not too surprised that your sister has a collapsed lung, and she also has a pneumonia. So what I've seen over the years there, Terry, is patients end up having chemotherapy and they end up being immunocompromised. And when they end up being immunocompromised to the point where they have no immune system left, no white cells, no neutrophils, they're often neutropenic, they're prone to having pneumonia. Patients end up on ventilators. And it's going to be very difficult to wean someone off a ventilator unless they can strengthen their immune system. So that's very, very challenging, Terry, in that situation. And you just got to give this some time and see whether her immune system can recover. I wouldn't be surprised if she's just been through a bout of chemotherapy just a couple of weeks ago, and then ended up with having no immune system, and then ended up in ICU with a collapsed lung and a pneumonia. I wouldn't be surprised if that is the case here, Terry. So, see how the intensive care stay goes. Also, if she doesn't need ventilation, that would be very good. If she can stay off the breathing tube, that would be good. If pneumonia can be managed with antibiotics, antivirals, antifungals, if it can be managed with BiPAP, CPAP instead of breathing tube and an induced coma, that would be advantageous, because once those patients are intubated, it can be very difficult getting them off the ventilator and the breathing tube, and you don't want that for your sister. Okay, next question. From Jolene. Jolene writes, they talked to my boyfriend's son, who is only 24 years old, into shutting my 50-year-old boyfriend's life support off after 12 days with an anoxic brain injury. He was opening and blinking his eyes, and they just shut him off and let him die. I can't believe that there is not more awareness made about this travesty happening in ICU units. It's been 3 months since his death now, and I can't help but think that we would be helping him wake up right now. This is criminal, absolutely criminal, and I can't talk to any of them about it because they try to tell me I'm saying that they're murderers. This is completely nuts. People need to be educated about these kinds of things before their lives are touched by these types of things. Yes, look, I couldn't agree more with you, and I'm extremely sorry to hear what you've been through here, what you're going through here. That you didn't know what you didn't know, or your boyfriend's son didn't know what he didn't know. He's probably completely oblivious to what treatment options are out there. He was probably completely oblivious that he had rights. He was probably completely oblivious that there's a big difference between what's a real and a perceived end of life situation in intensive care, right? And just because someone has an anoxic brain injury, that doesn't mean one should terminate life support. And I agree that if they did terminate life support whilst a patient is awake, that could be perceived as murder. It could be perceived as euthanasia, and either is illegal, right? So, and I agree that there simply isn't enough awareness out there. And I also agree that families in intensive care believe everything that intensive care teams tell them without questioning. It seems to be the state of the world at the moment, that people just believe everything that's being thrown at them without thinking for themselves and without asking the right questions. That's very, very sad, and very it really kills people if people don't ask the right questions. So, why is no one else talking about it? Are they all part of the system? Are they all part of the system? I really don't know. But you have to take responsibility, just as I said in the beginning. You, as a family, you have to take responsibility for the outcomes. If you are not taking responsibility for the outcomes, you are, you're in essence relinquishing responsibility, and you can't. You do not want to be in a situation like that where you need to write me an email like Jolene, where she's saying, well, we didn't know any better, and we just believed whatever they were telling us. This is a life or death situation. Why do you not ask questions? Do you just believe what people are throwing at you? You need to get into the habit of questioning everything. You should be questioning what I'm saying here. There's countless families in intensive care that come to us when it's too late. They say, well, can you review the medical records? My loved one has passed away. Can you tell me if there were other treatment options available? Yeah, there probably were. You didn't ask the questions when it was timely to do so. You got to ask when the iron is hot, not when it's too late. So that's very sad, this email. But it also shows once again that families in intensive care don't know what they don't know. They're not asking the questions. They're not doing their own research, which is incredibly, incredibly sad. Okay, let's go to the next question, which comes from Margie. Margie says, hi, Patrick, in your professional opinion, after 2 strokes and lingering high blood pressure, do you feel after being off the ventilator for 3 days, we can be fairly confident that my brother won't improve? In other words, he appears non-responsive. He's breathing fine on his own, but he doesn't appear to be cognitive. We don't want to prolong suffering if we know he wouldn't want to live in this condition. In your experience, do patients sometimes come out of this or show some signs of response or improvement the longer we wait? From Margie. Absolutely. Absolutely. He's been off the ventilator for 3 days. Yes, he's had 2 strokes, but you just need to give this some time. This is very early days, very, very early days. The reality is, how much time do you want to give this? The reality is, why would you give up now, right? You got to give this some time. And then it also depends, what's your perception of quality of life? What's your brother's perception of quality of life? Those are the questions you got to ask. Do you want to give up? You need to make decisions today that you don't regret in 12 months' time. If you regret today, or if you regret in 12 months' time to terminate life support for your brother, you will be doomed. You will be writing another email saying, well, I wish we only had continued, right? So maybe it's also about going home, providing end-of-life care, quality of end-of-life with intensive care at home, but one thing is for sure, if you're giving up, you never find the answers that you're seeking, right? There's plenty of time to talk about end of life. If your brother doesn't improve, there's plenty of time to talk about end of life. Don't rush into it. You will be regretting it. Now, Hope, you are now saying it's 2 years after post-COVID infection. They spent 2 months in ICU. The nephrologist has recommended dialysis and kidney transplant. Yeah, I think that makes sense, that this is where this unfortunately might be going towards dialysis and kidney transplant. That does make sense. So, but coming back to Margie's question, especially when you're saying your brother is breathing fine, and on his own, but he doesn't appear to be cognitive. Sure, you got to give it time. Recovery in ICU or after intensive care can take weeks, can take months, right? You just don't know. So that's my recommendation here. Do not give up here, and give it weeks, months, and see whether your brother can improve. Again, check out the interview that I said. Have a look at our podcast section, with the interview that we did with Joe, a previous client, where the ICU team said, well, he won't survive, and if he does survive, he won't have any quality of life. Look at his interview. He speaks clearly in a podcast saying, thank you so much for advocating for me, so that I can be with my family, so that I can live my life. The minute you give up hope, what's the outcome from that? You've given up hope. Okay, let's move on to the next question. From Donna. Donna writes in, my mom has COPD. She's in and out of ICU with too much CO2. They put her on BiPAP. However, they ask who's the power of attorney, and as if they may need to put her on a ventilator machine, but will do all the works, but the outcome may be catastrophic. What should I do if it happens again? Okay, all right. That's a great question. So my mom has COPD. She's in and out of ICU with too much CO2. Okay, she's a CO2 retainer. They place her on BiPAP. Then they ask who's the power of attorney, which seems to be yourself, as if they may need to put her on a ventilator machine with a breathing tube that would do all the works, but the outcome may be catastrophic. What should I do if it happens again? Right. I tell you what I think the answer here is, quite frankly. If she has COPD and she goes in ICU with CO2 retention, and she probably becomes drowsy, unconscious, and so forth, your best bet here might actually be to have her at home on BiPAP. That keeps the CO2 low, right? And that might eliminate the risk. Now, if she's in ICU and they can't get the CO2 down and she does need intubation, which is what they're basically referring to here, which, could have a catastrophic outcome if she's getting on a ventilator with a breathing tube into an induced coma, yes, that is certainly risky, or riskier, which once again brings me back to, can she be at home on BiPAP all the time? Again, service like intensive care at home can manage that at home. Make sure she gets the BiPAP, make sure CO2 is monitored at home, so that if CO2, for example, at home is high, do the BiPAP settings need to be changed? Okay, because that's what they would do in ICU as well. They would be giving her BiPAP, they would be giving her CO2, they would be eliminating her CO2, but it would be much easier to manage it at home on a regular basis, so that she doesn't need to go into ICU in the first place. Very simple fix, I believe. There could be other underlying issues that you haven't mentioned, but I hope that gives you some insights there that, many of our BiPAP clients at home with intensive care at home, they don't go to ICU because we manage the BiPAP at home, we monitor CO2 at home, and eliminate hospital and ICU readmissions that way. And that also keeps the clients away from the risk of intubating. So by you managing this at home with intensive care at home, you would be probably in a much safer place of not having your mom go into ICU in the first place. Okay, so I hope that helps. Let's look at the next question. From Jessica. Jessica says, my father is in ICU with septic shock and he is sedated due to the doctors causing blockages when he put a feeding tube in his abdomen. It got infected, and he also has early stage gastric cancer. That's probably why he's got an infection. Maybe my father is in ICU with septic shock and he is sedated due to the doctors causing blockages when they put a feeding tube in his abdomen, it got infected, and he's also early stage gastric cancer. So it sounds to me like, that there's been an issue around placing either a nasogastric tube or a PEG tube, and the issue around that might have been simply around the cancer. Now they had to put him into an induced coma. That's no good. But it's too little information, Jessica, for me to really advise you. The question is, if he's got gastric cancer, do they need to operate on him? Do they need to do a gastrectomy? Would that help him with containing the cancer? Right? That would be one of the questions that needs to be asked here, because there's almost no point in getting him in an induced coma if they're not, treating the cancer with, maybe again a gastrectomy, which is a partial removal of, or a total removal of the stomach. What would he need next then? Could he live with with a jejunostomy tube? Could he live with TPN, IV nutrition? Those are the questions that I believe need to be asked here. How big is the cancer and so forth? Has the cancer spread already? Those are the questions that need to be asked here. Okay, I hope that helps and answers your questions. I think I want to wrap this up for today, unless you have any other questions here while watching the video in live, or if you're watching it on replay, just post your questions underneath this video and I will get back to you. But in the meantime, if you have a loved one in intensive care, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. And also, if you have a loved one in intensive care and you need intensive care at home for your loved one, especially for long-term ventilation, tracheostomy, BiPAP, CPAP ventilation, even if your loved one is not ventilated but has a tracheostomy, please contact us as well. Doesn't matter whether you're in ICU or if you're at home already with insufficient support. We also offer home TPN services. We offer IV fluid services at home, IV antibiotics, and so forth. So that really helps us, or helps you with intensive care at home. If you're an NDIS support coordinator and you're looking for nursing care for one of your NDIS participants, please contact us as well. If you are and with intensive care at home, we are NDIS, TAC, iCare, NISQ approved service provider, also DVA. We also have received funding through the Department of Health. And if you are, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care and intensive care at home related. I also offer one-to-one consulting and advocacy for families in intensive care over the phone, via Zoom, via WhatsApp, via Skype, whatever modality works for you. I talk to doctors and nurses directly on your behalf. We can set up three-way calls. I can represent you in a family meeting. I can, participate in them and really give you that second opinion that you will need in a situation like that. We also review medical records. We provide a second opinion in real time. We also review medical records after intensive care if you have unanswered questions, if you need closure, or if you're simply suspecting medical negligence. We offer all of that. Also, I do these YouTube lives once a week, generally speaking on a 10:30 a.m. on a Sunday, 10:30 a.m. on a Sunday, Sydney, Melbourne time, which is 8:30 p.m. in the US Eastern Standard Time, 7:30 p.m. Central Time on a Saturday night, 6:30 p.m. Mountain Time, and 5:30 p.m. Pacific Time on a Saturday night. That's when I usually do these YouTube live streams, and you can come on the show and I will answer your questions in real time. Also, if you and I would really appreciate if you give the video a thumbs up, give it a like, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. click the like button, click the notification bell, and comment below what you want to see next or what questions and insights you have from this video. And thank you so much for watching. This is Patrick Hutzel from Intensive Care at Home and Intensive Care Hotline, and I will talk to you in a few days. Take care for now.